the next study that I think we're going to hear about is the second strategy, adding an anti-VEGF to a checkpoint inhibitor. Tell us about your study, Katie Moore, Imagine 50.
Sure. Imagine 50 is a randomized phase 3 study, 2-arm. It enrolled all histologies except for mucinous, so very different than what we've just discussed. All of those studies, prima palavelia, all were limited to high-grade serous and some high-grade endometrioid, but this allowed clear cells as well. Biomarker stratification was PD-L1, and so that is an important difference between our study and Javelin's. We are stratifying there, and then randomized to paclitaxel, carboplatin, placebo maintenance with bevacizumab. So everyone gets bevacizumab throughout, and then placebo maintenance, or paclitaxel, carboplatin, bevacizumab, atezolizumab, and then atezolizumab, bevacizumab maintenance. It's a dual primary endpoint of progression-free and overall survival, and finished accrual in April of 2019, and we are in final stages of data cleaning. So,
Sharon Lewin, you're an advocate of this trial, and you enroll in your practice called FIRST. Tell us what FIRST is.
So FIRST is presently open and enrolling patients. Very interesting study for women with stage 3 and 4 epithelial ovarian cancer. So it's looking at sort of standard of care, which is paclitaxel and carboplatin IV. Interestingly, with or without bevacizumab, so looking at the role of VEGF. And then patients are randomized to either dostarlimab or placebo in cycles 2 through 6, and with or without Avastin, based on your prior decision. And then there's a maintenance phase looking at either niraparib or dostarlimab or placebo. So sort of a complicated schema looking at the different formations of that. But again, it's just looking at the combination of dostarlimab, bevacizumab, and niraparib versus placebo.
Yeah, we're excited, and I enrolled to that too, and we'll have to see what happens. And then I have a study called ATHENA. ATHENA is a pure maintenance trial. It distinguishes itself from these other trials sort of in the PRIMA sort of theme, where we focus on the maintenance opportunity. It is just a simple question: should we add a checkpoint inhibitor to a PARP inhibitor? And so 400 patients get maintenance PARP, sort of a la PRIMA, and that PARP inhibitor, of course, is rucaparib. And then 400 patients get nivolumab plus rucaparib. And integrated into that is a placebo. The first endpoint to report will be sort of the PRIMA population. We'll do that first, meaning not the PRIMA population, but the PRIMA opportunity, just PARP versus placebo. And then over time, we'll do the primary endpoint, which is rucaparib versus rucaparib nivo. And there is a small nivolumab arm of 100 patients. So it's 400 rucaparib, 400 rucaparib nivolumab, and then 10% or 100 nivolumab, 100%, 10% placebo. This trial has finished enrollment within the US. It's just winding down. And this will probably be, at least the rucaparib versus placebo arm, will probably be the next study to report after Imagine 50 in the frontline setting. So let's go ahead and end there. That was a comprehensive conversation about frontline treatment, really leveraging the opportunity of GOG 218 and bevacizumab, approved in June of 2018, and then ultimately the opportunity for SOLO-1, PARP inhibitor and maintenance therapy, and then PRIMA, PARP inhibitor beyond BRCA, and then ultimately the combination PALA-1. So I want to quote my good friend Tom Krivak that says, it's a maintenance world, and the most important thing is that maintenance is used. And I'm going to quote my good friend Katie Moore, who says, I just don't understand why people would think that these patients with advanced ovarian cancer are cured. And so there's a synergy there that if they're not cured, we have the opportunity to keep them in response. And all of these studies did not show a decrement in quality of life.